Hello, ladies and gentlemen. Welcome to Triple in the Media. I am Dr. Nick Nikam. I have been a cardiologist for more than 40 years in the Houston area. The feature presentation is dual versus mono antiplatelet agents following PCI. It is quite clear that most of these patients need to be on dual antiplatelet agents for a minimum of 12 months if they are getting a drug-eluting stent, or a minimum of 30 days if they are getting a bare metal stent. But beyond 1 year, there are no clear-cut answers as to how long they need to be on. There are certain conditions like following surgery, they need to be on antiplatelet agent for long term. But however, those patients who receive stents, how long do we continue? What happens if we stop the dual antiplatelet agents at the end of 1 year? Should they be on dual antiplatelet agents? Should they be on monotherapy? And what are the risks associated with dual antiplatelet agents, namely bleeding? So let us see what we can learn from this particular study that was reported in JAMA Cardiology on September 28, 2022. Long-term effects of P2Y12 inhibitor monotherapy after percutaneous coronary intervention. This is a 3-year follow-up study. In the first 3 months, all these patients received dual antiplatelet agents, namely aspirin and clopidogrel. And between months 4 and 36, they were on single therapy, namely clopidogrel. This is a pretty large study, and here's the study design. They had 2,993 patients who participated in the study, half of whom were treated with the P2Y12 inhibitor 3 months after they were on dual antiplatelet agents, and the other group received the conventional dual antiplatelet agents as most people are getting in the present day practice. The average age was 64.5 years, and this is a study that was reported from Korea, which involved 33 different hospitals. We're going to look at some of the outcomes and what we can learn from this study and how we can apply that in our everyday clinical bedside management of cardiovascular patients following PCI. Looking at the primary endpoint of cardiovascular events, the MACE events, these major adverse cardiovascular events and cerebrovascular events all combined together. As we can see, those who were receiving the dual antiplatelet agents had similar instances of these MACE events compared to those who received only P2Y12 inhibitors, and the difference was not statistically significant. This landmark analysis, that is between the 3rd month and the 36th month, that's the group which was getting only antiplatelet agent. There was no significant difference in the monotherapy group compared to the dual antiplatelet agent as far as adverse major cardiovascular events and cerebrovascular events were concerned. Here's the same study that looked at the bleeding instances in patients who were on dual antiplatelet agents versus single antiplatelet agent. Now let's look at this BARC, which stands for Bleeding Academic Research Consortium, and there are different levels of bleeding which have been characterized, so we can sort of quantify the degree of bleeding, and you can see the outcomes in this particular study. The bleeding type 2 to 5 BARC classification, the patients who received dual antiplatelet agents had a higher incidence of bleeding compared to those who were just getting a single antiplatelet agent, namely the clopidogrel. It was approximately 3 compared to 8% incidence of bleeding. And when they looked at the same study with major bleeding instances, the major instances were still slightly higher in the dual antiplatelet agent groups compared to those who were on single or mono antiplatelet agent. When they looked at the study between months 4 and 36, again, the difference was quite significant in patients who were receiving dual antiplatelet agents, and similarly, major bleeding incidences were higher in the dual antiplatelet agent group compared to the P2Y12 inhibitor monotherapy. And here is a breakdown of major cardiovascular events. As I said, there was no significant difference in all-cause mortality, cardiac death, myocardial infarction, stroke. The only difference that was noted was bleeding, which was 44 in the monotherapy group versus 112 in the dual antiplatelet agent group. Net adverse clinical and cerebrovascular events were much higher. Of course, when you add the bleeding, the overall incidence was higher in the dual antiplatelet agent group. But besides these bleeding problems, the rest of the adverse cardiovascular events were similar in both groups. So it tells a lot about what we can do if we are in a situation where there is increased propensity for bleeding and you want to decide if you want to keep these patients on a single antiplatelet agent or a dual antiplatelet agent. So this study clearly gives us some confidence as to what we can expect when these patients are maintained on like single or mono antiplatelet agent for any number of reasons more related to bleeding than just antiplatelet activity. And again, this is looking at the landmark, that is a study from 3 to 36 months. We have almost identical results, which we saw in the graphic form also. So the key points we need to take are those patients who received dual antiplatelet agents versus those who received mono antiplatelet agent. The cardiovascular events in the mono antiplatelet agent were not different from those in patients who were on dual antiplatelet agents, with the exception of the bleeding, which we already talked about. So, ladies and gentlemen, this is a very quick overview of this study. A few take-home messages for a clinician is, if you are dealing with a patient who is having increased propensity for bleeding and you want to manage them with just one antiplatelet agent, then this study sort of gives some comfort that yes, up to a period of 3 years, when you treat these patients with mono antiplatelet agent, their adverse cardiovascular events are no different from those patients who are receiving dual antiplatelet agents. In the past, we had seen studies where if you stop the antiplatelet agents, after 1 year, there was an increased incidence of thrombosis and increased incidence of myocardial infarctions. But that was not the case in this particular study. Thank you so much for watching this presentation. We have numerous presentations on many cardiovascular diseases. Please do watch them, and please do subscribe to our YouTube channel. I also have ACC/AHA guidelines from 2014 all the way up to 2022, and most of them have been presented here in a short, succinct manner, so you can watch them to update yourself with the ACC/AHA guidelines. I'll see you in the next presentation. Thank you so much.